All right, once again, good morning, everybody. My name is Angad Buttar. Welcome to our webinar today. It's our fourth session in our Continuous Quality Improvement Learning Series. Our session today is on leveraging staff and patient feedback to help improve your operations. What I'll go ahead and do is get started here. I know people are still joining, but I do want to be respectful of everyone's time. So if we can go to the next slide, I'd like to go over quickly the session agenda for our webinar today. First, we'll go over our Atlas Patient Experience Survey process, go into some detail there on the structure of the survey and some initial results that we've seen. We'll introduce our featured speakers for today. Then we'll conduct hopefully a robust Q&A session as well. And then we'll end the session with some final thoughts on our 2020 CQI Learning Series and our plan for 2021 as well. Next slide, please. So when folks clicked on a facility profile in Atlas, below the signs of high quality care, our patient feedback is displayed. So the responses to our patient experience survey are closed-ended survey items that are displayed in the manner in which you see here. Responses are collected via a Leave Review button, which is circled on the upper right-hand corner of the screen in the facility's profile and are analyzed and updated every 24 hours. Responses are anonymous, but are subject to natural language processing and various algorithmic reviews to screen for potential fraudulent responses. Data are publicly displayed on facility profiles once 20 responses have been submitted, which is the minimum threshold to protect patient anonymity and prevent biased results. Next slide. So a bit about sort of how the patient experience survey is structured. Questions are, there are 10 survey items that consist of 7 multiple choice questions, 1 open text response question, and 2 demographics questions. As I mentioned earlier, responses are anonymous. And the non-demographic questions are recommended by an expert panel with the National Quality Forum. There is a robust validation process, which I mentioned, in terms of natural language processing, but also a human review, again, to make sure responses follow Shatterproof's terms of service. Next slide, please. So on this slide here, I'll quickly go over these next few slides as we wanted to go over sort of the 7 quality measures in the patient narrative that comprise the patient experience survey. So among the initial measures are access to treatment, access to behavioral health, overall quality rating of the treatment program, respect, family and friend support, amount helped by treatment, improvement in the ability to function, and patient narrative and treatment experience. So I didn't want to go into too much detail here. As we send the content out, you can read a bit more about the specific measures. In terms of the 2 demographic questions, we'd like to get an understanding of who is completing the survey, so whether it's the individual receiving the treatment or if it's a family member and loved one. And then last but not least, the duration of the treatment as well. Next slide. So here, our patient experience survey response rate has been steady since November 19th, when this data was last populated. We've received over 11,500 responses, and as we enter next year, we look forward to continuing to partner with our treatment facilities to promote and increase survey participation. But the data here kind of gives you an idea of, based on each state, where the survey responses have come in, again, as of November 19th. Next slide, please. Thank you. On this slide here, you can see by state the number of facilities with at least 1 or more response. And then on the right column, those facilities or those states with facilities that have 20 or more submissions. And again, as you'll recall, as I mentioned earlier, once the survey has 20 or more responses for a facility, that's when it's populated to the site. And again, we look forward to working with our facility partners to sort of promote and increase these numbers. Next, I would like to turn it over to my colleague, Carolyn Davidson, who who will talk about response rates from some of our survey questions. Carolyn?
Thank you so much, Angad. And hello all, so happy to see you on this Thursday morning. So this data might look a bit familiar. I'm gonna go through very quickly what we saw in terms of trends from the patient experience survey. And these are based on the patient experience survey results that we collected as of January 31st, just to note. But we expect that these trends will continue as the bulk of responses were collected by then. So these are divided by the Shatterproof principles of care, just as the signs of high quality care are in the facility profiles. On the principle of fast access to treatment, 60% of patients reported that they were always able to see someone from the treatment program as soon as they wanted. However, among facilities that had at least 20 responses, so that threshold that Angad mentioned, for a quarter of facilities, 50% or fewer of patients answered always. Now thinking about effective behavioral health strategies and thinking about how these relate to patients and patient respect. So looking at patient feedback collected, 75% of all patients reported that facility staff always showed respect for what they had to say. Among facilities with 20 or more responses, so again, that threshold, the top 10% of facilities had more than 97% of patients answer that staff always showed respect for what they had to say. Looking at additional services that support recovery, which in this case can include also the importance of family and friends in the treatment process. 81% of patients reported that the staff at the facility talked with them about including family or friends in treatment. And for facilities which hit that 20 response threshold, the proportion of patients that selected yes ranged from 47% to 100%. So you can see that there's significant variation across facilities, but also that this is a fairly positive skew. And when we're thinking more about outcomes, and of course these are more of patient-reported outcomes, but 80% of patients responding to the survey said that treatment helps them a lot. 15% said somewhat, and 5% said a little. And also to note that with the patient experience surveys, when we analyzed the data, we found that the results tended to be similar within facilities and different outside of facilities. So what I mean is that facilities tended to skew in one direction or the other in terms of the positivity or negativity of patient responses, and we were able to differentiate between facilities based on these responses. And now comes the part where I will turn it over to our fantastic speakers. I'm so excited. Oh, sorry, I was moving my mouse too fast. So I will start by introducing the amazing Tommie Ann Bower. So Ms. Bower is a consultant to the Massachusetts Bureau of Substance Addiction Services. And she does training and coaching using the NIATx quality improvement model. Her work is informed by 3 decades of program and grant management experience with the challenges of adopting practices that could reduce suffering of clients and families. And she credits the 2003 Robert Wood Johnson Foundation Process Improvement Grant with maturing her tendency to simply study outcomes into a commitment to work to make every encounter a potential tipping point for recovery. In 2005, after working as a change leader for projects on residential and detox completion rates, she began coaching other agencies and worked on projects in several states, as well as NIATx 200, CSAT, and MBHP. She credits the ARISE intervention training with helping her to embed concurrent family services as a practice in all residential care. She served as Chief Clinical Officer of Gosnold on Cape Cod, and over the years presented on issues regarding women, pregnancy, and improvement at ASAM, NIATx learning sessions, RSAT webinars, and CSAT. She jokes about retiring that when every access point of treatment is equitable, fully trauma responsive, as well as mental health and addiction informed, and serves the family. And on top of all this, she is grateful to be in very long-term recovery. And Tommie, I'm going to pin you at Spotlight. There we go. And then next I will introduce Abby as well, so everybody can see both of your amazing faces. Abby Deem is a MSW MPH, and she has been working to get programs and treatment to meet the needs of those they are meant to serve, first as a clinician, and more recently as a program designer and director. She has created, developed, and run inpatient and outpatient programs for individuals with mental illness, substance use disorder, and for families. And she currently hosts an award-winning weekly radio show, Right Mind Media, and provides treatment and education at Brookline High School, not Brooklyn in New York, Brookline High School through the Brookline Public Health Department. And with that, I will turn it over to both Tommie and Abby.
Good morning. I'm going to just get my screen shot up here. Whoops, there we go. Have it share screen. There we go. And one more change here. Good morning, everybody. While we get the slideshow up. All right, here we are. So good morning. We have a lot to try to do today, and we do have some, both Abby and I have some goals for you, and hopefully this will be helpful in this rather difficult time. So both Abby and I have worked with NIATx for a long time, which is really just a model, a blueprint that was formulated over a fairly long period of time. There's lots of practices in this version of CQI. So we'll go over how that is. We want to look then down into those structures, specifically at the roles and the functioning of change leaders and change teams as drivers of process and quality improvement. We'll outline a bunch of specific kinds of processes to engage staff in developing ground level data to frame PDSA tests. And we'll talk about some informal methods to supplement the high level data, the survey and performance data that you're getting and have always gotten. And we'll use some examples of staff and client engagement. And then at the very end, I'm going to do a little chat about moving from the spirit of improvement to an actual infrastructure of continuous improvement. So many of you know this, but one of the reasons that I'm using this kind of simplistic metaphor is to give you some places to start talking with your staff, the staff that can actually drive improvement at the ground level. So I've been a commuter in the Boston area forever and ever, so I'm very used to listening to traffic data from a helicopter. And often the traffic is backed up in some place like the Southeast Expressway North, and they'll give you something like it's at Neponset Circle. And then they'll say there's a tire changer in the breakdown lane. And this is traffic on the 3. So every 10 minutes you get another version of this, another tire changer. The usual backups are now back to the split. There might be a truck off the side. And the question is it a usual traffic backup? Is this what is normal for us? And if you're sitting in traffic, of course, you may or may not know what the root cause of this situation is. The issue is that often it's something like a pothole. And in our processes, often we have big data that suggests our admissions aren't working, they're not timely, etc., or the dropout rate is high. But we often don't know what are the potholes of this process. Where exactly is that pothole? And how do we get communication and observe when the potholes are coming? So some of our work in traffic potholes is predictable. So in Boston, you can see a lot of potholes all over the place if there's been a lot of freezing and thawing in February, March, and April. And they're really pretty destructive. So that's the pothole metaphor. So this NIATx thing was really initiated in 2003, and that's where I began to be involved. It entered the world of substance use disorder treatment. It's been around in many names, Six Sigma and Lean, and all kinds of versions used by IATA and other things. In our world, in substance use disorder treatment, the original aims were reduce wait times and dropouts, and also increase admissions and completion rates. And a lot of that's still relevant. One thing I'd like to note, because I'm going to try to talk about that we don't know where the potholes are unless we're looking for them. But also we get used to our treatment as usual, even though, and we don't question it. So in 2005, there was a study that showed that the NIATx involvement reduced wait times from the first request for a treatment to an actual treatment from 32 days to 12 days. This was an acceptable form of treatment, and we know that seeing what is embedded in our way of delivering things is a common problem. And so hopefully today we'll give you some ideas about how to locate those. So in the NIATx way of doing things, this is a set of strategies to do something about the problems that we have. It starts with an executive sponsor, somebody who's designated to hopefully align the organizational mission to an actionable aim. And then it goes down into the place where the people who are near to that aim or that issue live. And the executive sponsor assigns authority to a change leader who builds an early adopter change team. That team gathers formal and informal data, and we'll talk a lot about that. And the person those people generate solutions. So that is one of the unusual things. Instead of the usual thing that I did when I was, before I met process improvement, is I would generate all of the ideas, take them to the staff, and then push my agenda onto the patients or clients without really checking things out. So this is a much more orderly process for implementation. I've just mentioned it briefly. We also teach when we do these trainings how to build the clinical case so that everybody knows what's in it to do the clinical modifications. And we include the business case, which we found to be very interesting and helpful for staff to engage and buy in. And the final two things, one of which most people know, is rapid cycle testing. Instead of having a strategic plan that takes 6 years to implement, or waiting until the Joint Commission comes back in 3 years and you spend a year making yourself crazy. You do these little tiny tests. And the final thing that's rather new that we've added in, because there's some evidence that shows that it's quite helpful in pushing improvements through, is coaching. So I want to start briefly with the change leader, the qualities. This is a person, as I said, appointed by whoever the executive sponsor is. There's delegation of authority. The person must report to the executive sponsor. There needs to be a relationship there. There needs to be some time and resources dedicated to these processes of looking for what's going on, where are the potholes. So of course you need somebody who's going to be comfortable challenging status quo. I don't mean you're complete rebels, but somebody who sits there and is able to say to you, why are we doing that? This protocol that the state has us do at the beginning of our intake. The second quality that I think really stands out, you can read all these others, but it needs to be somebody who is comfortable with data. They don't have to be able to do run charts themselves, but they need to be able to value that when we have data, we're looking for data that will help us know that our change is actually an improvement. So most of us have good ideas, but they're not actually going to push the data in the direction that we want. So the next thing is that we want to make sure that we have somebody who's sort of has some Sherlock Holmes kind of characteristics. They're interested in finding out, how do we find those potholes in advance? And who's going to watch those potholes? And can we do this predictively? Do we have to always wait until 3 cars die of potholes? So the next thing you do is you actually form the team, and I'm going to speak briefly about team composition. Usually we do one change, one level of care. And the only time that we change that is when you're doing a cross silo kind of change where you're trying to hand something off, your handoff from detox to the MAT program when the person goes home is messy or incomplete or very difficult. So the next thing you do is invite people who actually are close to the problem and people who can fix the problem. So even if you don't know exactly how you're going to do that, but you make educated guesses. So for example, if you're really revising the flow in your admissions process, you are probably going to need to have some IT revisions. So you might invite your IT person to be engaged with why you think it's a problem. We strongly recommend that you recruit the people who always raise their hand and say, oh yes, I'd like to learn this, so that you're actually forming a little bit of a piloting team, people who can go and test out new clinical procedures or flow through. Please consider, especially if you're new at this, please leave your curmudgeons for later. You can always bring them along, and it really is, the idea is to get going here. So the word rapid and now are good in this version of process improvement. You teach your team, then you have to teach them how to look at things from a different perspective. The perspective is what's going to improve some of your processes and your clinical delivery. And the easiest way to do that is to just ask your team what they know about what is a good quality food delivery service or something that's close, and then get them to start be interested in how wait times could be improved. So if you have people who are trying to get an appointment for a COVID test right now, that's very difficult. And it's an interesting process to discuss. It's always nice to know what data or what outcomes matter to the team. So we're going to stop now and actually ask you to do just a little writing in the chat about waste buckets. And waste buckets is an old idea. There are almost always like 5 easily identifiable wasteful processes, whether they're in your intake or some other place that you know should be fixed. So if you wouldn't mind, you can do it anonymously. Just please type in a couple of those in the chat and let us see what you have, and you can do it anonymously. So we're going to open the chat. And I can't see the chat. So let me see if I stop sharing. Can I see the chat? Is there anything in the chat? No one's writing that.
So I have a chat open, Tommie. I don't see anything just yet.
All right.
Yeah. So we'll, as soon as they come in, we will let you know.
Okay, good.
And I know Tommie mentioned anonymity. Unfortunately, there's not yet a way to be anonymous. Oh, thank you, Joe. There's not yet a way to be anonymous in the chat, but if you would like, if you feel that you don't want a particular person knowing, you know, feel free to message Angid, Leah, or myself, and we will relay to Tommie and Abby.
Okay.
Looks like we have our first answer, Tommie. Joe Adams says, going through the motions with satisfaction surveys that are not anonymous or helpful.
Okay. Yes, going through the motions. Yes. And often surveys are actually not that informative of those ground level things. They're either very generalized. So that's actually a really good one.
One from Rhonda Rock. Unidentified waste in healthcare could be defects. Oh, a bunch of people just entered it and I lost it. Hold on. Could be defects, waiting, transporting.
Right.
Robert answers, do things that just check the box with no real purpose.
Absolutely.
And from Helen, redundancies in documenting in the EMR, getting rote answers without engaging in deeper clinical discussion to satisfy external agencies.
Yes. Yes, you got it.
Let's see, any other answers from the group?
Okay. Well, let's move on then. That's you got it. These are the things, and I'm sure if you're listening to this, you know that there are a bunch of other things. So let's go with what do we do about this? So let me start with something, the informal focus group data. So instead of taking your survey, you could spend a little bit of time organizing a little conversation with people who are receiving a service. And you don't have to have a huge agenda. If you have a hypothesis about what might help something, and you're in that part where you're developing ideas about how to improve something, you can actually sit down and introduce yourself if they don't know you, etc., ask permission. And it's not a gotcha thing, but you might ask for their help. So I've used this really in a lot of different ways. One of the people I work with, Megan Ralston, who's out in a large center in Breen in Western Massachusetts, we worked on her going, and they had a very lengthy 24 session IOP, and people were dropping out. And she was trying to improve her retention with that. And what she did was sit outside and simply talk to people. And she discovered in doing so that some of the problems were, of course, transportation in Western Mass. There is an answer for that, but it wasn't easy for the participants to get to that answer. So another example was I had done a lot of work in a residential women's program to improve my retention and completion rates and reduce my dropout rates. And I noticed an uptick, and I started paying attention to it again because one of our teenagers left that we had hoped to really work with. And we had a really beautiful place. We had done, as far as I was concerned, everything we could to retain people in treatment. And I discovered when that the mother called us and said, my daughter couldn't get a pillow, and there wasn't a pillow on her bed, and the linen closet was locked. So that was, one of those horrifying, terrible little tiny micro things that no survey would probably tell me. And I fixed that problem, but then started listening to what happens in the first day and how could I make it more easier for a person to enter our system. I also noticed that my staff, who were loving and caring and kind, also sort of skipped over things that might be from the patient perspective. So I decided that with lots of people involved that we should try a peer mentor, so assign someone to the new person to walk them through the first day or two. I, oddly enough, went and sat with some of my current patients at the time. I said, what about this? They said, oh no, we hate that. We don't want to do that. We don't want to ask somebody that we don't know. Something will look stupid, especially the teenagers. So what we did was organize a kind of first day guide for them. And it was really, we had them help us tweak it so that all the little pieces that we wouldn't think of as staff, the where's this and that we're sitting up here, we know what the process is. We know where the linen closet key is, for God's sakes. So those are things that you can use that to test a hypothesis that may or may not be helpful, but also just the anything else going fishing for where are potholes that you will not see. Another way to really get started is without a lot of time or energy is to simply flow chart any process, any piece of time. And I put together, there's a process that you can do in Microsoft Word to actually look at what's going on and where the pieces are and where the decision points are. For very complicated systems, I used to use that little Ishikawa fish diagram that has a little head of the fish that says, where are you going? And then has little spines. You can endlessly look at the other things that drive the process forward. But for many things that you're working on, that doing those on the ground things that can be fixed right away, just simply doing a tiny little roadmap and looking at where the potholes are. So when I first did this at a detox, I discovered that the detox admission process was completely stalled out for the lack of a recovery aid to look through the belongings. I mean, and so we fixed that. And that I found out through a flow chart, and it wasn't a pretty flow chart. So the other thing we want to do here is, I'm going to talk quite a bit about using a walkthrough process. Some of you know this, and if you haven't done this or used this as a resource, I want to tell you why we use it first, and then I want to tell you how we use it. So now maybe I should tell you what the deal is here first. Okay, so pick a part of any process and it's a role play. There's no secret gotcha thing. There's no secret shopper. It's simply a part of the process where somebody is playing the client, and preferably somebody else like a family or a friend or whatever who's there in any part of the process. And the person who's doing an intake or a walkthrough or a handoff or whatever, those people do what they normally do. It is absolutely an invitation to help with improvement. So why do we do this? The originator of a lot of this stuff, this adaptation of CQI to substance use disorder treatment, had a wife who had a hospital situation. And this is Dave Gustafson, who originated CHESS and has done a lot of work on applying processes to things like the DDCAT and other kinds of issues that we have. So at some point he got a survey, and the survey was really made him quite upset, because the survey was really about the hospital. How did we do? Where are we good? And what he realized, because he had watched his wife's process, that the survey was completely out of sync with what the client experience was, the patient experience. And so from that point forward, Dave actually got himself admitted to an addiction detox in order to see what was it like, what was the experience like. So this is an empathy builder. When you listen to, as playing a patient or a family member, your intake, you will see that you will absolutely go insane about those useless questions that aren't connected to clinical rationale, and the ones that are repetitive. So this is the simplest process that you can do to discover things that you would otherwise not know. An analysis, this is a great analysis for engagement. What is it like to be a client in your agency? And what is it like to be a family member trying to get information, or just watch the process? And I put this little thing here with the shoe falling because until I really worked with family members, I really didn't understand what it was like to be a family member dropping off a patient to a level of care and not know. So we started a whole series of family programs, free and also structured, a little informational engagement, etc. We ramped up a simplistic but effective intervention service. And we had some people in the community who had children who had long-term troubles. One of them spoke one time, and she was, I was standing behind her. She was at the podium, and she suddenly reached down and she took off her shoe and held it up. And she said, "This is what it's like to be a family member." and she dropped the shoe loudly. So that perspective changed my entire commitment to do family, which I didn't really understand. So developing empathy. So some of the other things that are common sense that you can see if you do a walkthrough, you'll see those signage issues. I would like to mention briefly that in residential, often it was, who is my counselor and when can I meet them, were much more important than anything else. Not questions that I would have thought about because, you know, I assigned the counselors. I want to talk now about why we do iterative improvement walkthroughs and the value of that. And I want to mention burden of illness, because this is another thing where it is just, we see in our business people who are terribly, you know, suffering in lots of different ways. And there is a certain natural process where we start to screen out that suffering, where we can't hear it because we can't get through it. So there is a normal process where we remove ourselves from that experience that the patient has. But I want to suggest that you do a walkthrough looking simply at burden of illness. And by that, I mean the simple things. Are they in withdrawal? Can we give them comfort meds before we dose them with something to help with the drug? Can we do something before we get the authorization? Are those simple things, the food, the water, is the bathroom accessible? Do you have to go and beg somebody who's behind a plastic screen and then interrupt them to find out where you go get this and that? I would also like to make a big pitch that as people look at systems, that they ask themselves, is it tolerable for our most compromised clients? Is it trauma responsive and not just trauma informed? Are we actually responsive to the predictable needs of someone who's gone through really a lot of suffering? Most of the people we see are going to bring those other things. This is not new information. And yet the system is not always designed to actually be responsive to those, to that. You can call it baggage, you can call it the additional co-occurring stuff of homelessness and grief. So developing a system that can be responsive, that, and all the way down the line from the person who says hello or your website, I think is really important. And it's going to improve engagement and retention at the point of our first conversations. So the other issue that almost all of us are experiencing in real life now, are we there yet? Is the vaccine here yet? Do I have to go through another Christmas? Is it going to be, how long is this going on? And when you're in a new system that you don't know, are we there yet question is really compelling. And it's also another burden of illness that we often expect people to come in and spend X period of time, and we don't really tell them what that's going to be. So developing checklists for the client is something that you can do. We're going to go through these 16 things. And every time you go through another one, we're going to have the staff signed off. So we know we did it, but also you know you did it. So there's a shared ability to say this is going on too long. At Mass General, at one point, they would do all of the pre-op stuff, put everybody in one room, give you this card, and let you, so that you actually knew who you hadn't seen, but they did too. It was a really brilliant, simple thing, but it declines the stress of that experience, and you're hopefully some of these cumulative things will help you get some of your potholes taken care of. Here's some other things you can think of. You can do just through the walkthrough. You really should look at web access. We have a lot of issues. I've noticed that a lot of websites now are, would you like to talk to us? And, you know, there's one that I saw where they say, okay, you could talk to us, but here's everything you need to know. Here's the little videos. And if you're thinking you might need something more than just this, need to think about the language in many places, like some of the small hospitals in northern Massachusetts that have significant services for mental health and substance use disorder. Their websites are organized by departments. You can still find this at Mass General, by the way. I have to tell them that, where it's behavioral health. And if you're a parent, you may not know what behavioral health is, or if you click on that, you might be able to find some service. So it's worth looking at. You can do a separate walkthrough for stigma and actually begin to identify places where stigma is alive. Many times under stress, we regress and we start thinking old models of treatment. Language and culture, equity, where are our limitations? And a walkthrough is one way to begin to notice those specific things in your flow through. Are we culturally sensitive, or are we just doing what we know to do? And often we do what we know to do. So the other place that I see problems are outdated facts. Please take a moment to do that. And in general, leaving this part of it, I would like to have you notice that many of our intakes, we take things from the patient, and especially an outpatient, and in these days where telehealth is overburdened, we don't really, if we just do our formal intake and get our authorization, what have we really returned to the patient? An appointment? So we did a couple of years ago, we did one of our Massachusetts basic introductions, and we had a medical director who came and listened. We stuffed that person into a group with other people because people come in groups or whatever. And at the end, we ask, what's one thing that you're going to try when you go home? And the medical director said, I am going to mandate to my staff that they talk with the patient or the prospective client for 30 minutes before they pull out any forms. So maybe that you can't do that, but it is something definitely to think about, especially for engagement and retention. So a couple more things. What do we do with all that informal data? Okay, now you know things that you don't want to know. Oh, you found 500 holes. So as you pick that aim, what are the primary things somebody has to put the focus in on? And then you think about what are things that we could actually do something about, and you modify this to pick something that you're going to work on. Then you get your team together, who hopefully has done some of the walkthroughs and helped with all of those informal data gathering. And I just have to look at the time here. Okay. And you do silent generation. This is called a nominal group technique. It is a disruptive process. It sets in motion improvement kind of strategies versus clinical top-down, you're the supervisor. Here's what I'm supposed to do in my normal world. Clinical supervision is not necessarily useful in terms of some of this. So it's a different way of working. So you ask all of the people there to write down one idea for improving whatever your aim is, and then you had them share it out loud or put it in a Post-it. In a breakout room, we've done this, and they do 5 to 10 ideas, and each person goes round robin. Then the kicker is that you get 5 little dots or votes, and here's where it changes everything. You can use your votes as a team to put all of them on one idea or spread them out. So what this does is level the usual restrictions or the silence because the supervisor who's having a bad day or the supervisor who's gorgeous and we love the person, they're the head and we want to please them. So it disrupts all of that normal mechanism that we all have. And then the idea is you pick stuff and start doing the PDSA. Okay, so I want to give you some examples of where you start. And I've labeled them BC, that's before COVID, and So this is a BC access example. So access is huge. And I know agencies, and Abby knows agencies who worked on access, same-day access for years and managed to get from little tiny experiments to spread that. That is very common to happen over a period of time. So Place to Start, an agency that I worked with in Connecticut, was right across the street from a court. On Wednesday afternoons, they had a really high no-show rate, but the court really wanted to send people over when they got through saying, hey, you need a substance use disorder, you might be a drunk driver, and you might have a substance use disorder diagnosis. So what they did was actually just take a chunk of time and said to the courts, send over anybody you've got from 1 to 5 or 1 to 3, and we'll take them. And they just did 2 clinician pilot and provided some non-clinical support to help make all of the mechanisms, the junk, you know, the name, address, etc., done beforehand. And so they took their 2 willing, and they learned how to adjust sessions or how to bring somebody else in when they had a pileup, and how to take care of the people who were waiting. So this made the clinicians very, very happy. It's great if you have fee-for-service people, is to do some sharing and to make that a pattern of access. So that's one. You can play around with that. The second is an actual implementation that was done in a mental health. So I'm going to talk mental health for a minute. They were part of a project that we did in Massachusetts, where we invited them to come to our little learning collaborative, learn process improvement, learn the DDCYT and get assessed for that and have training on it. That's the youth version of the DDCAT. And this agency said, oh yeah, I'd love to learn how to deal more effectively with substance. Are you kidding me? And they were very, very honest that their staff really had this was like not gonna fly. But they had a lot of youth, and they had a really important piece of data. It was 800 people, youth, and only 17% of them were screened as positive for substance use disorder. And they kind of knew that that was probably not good. So we did a little thing with them, and it turns out they had the craft, with a simple old-fashioned craft in their EHR. They went to their Christmas party and said, hey, is anybody interested in doing this craft, trying to pilot this? They got a bunch of clinicians. They worked out all of the little clinks, like when they got a positive, no one had trained them what to do about it. How do you refer people? How do you make those decisions? So the agency really helped them to move that into action, gave more support, supervision. They hired a dual diagnosis capable staff member, dually licensed, to increase that. And they set 100% implementation goal. So finally, this is one of those things. So often, as I said, we don't know what we're missing. So one of the things I've been thinking about is the people who are in recovery, but who are under incredible stressors right now, financial, emotional, the people for who got through into recovery, but have not had a chance to really deal with either PTSD, they're muscling, they're still doing that, I'm surviving, I'm muscling through. The people whose anxiety diagnosis, their depression, their grief, the amount of grief around right now that doesn't get into the normal system of care for recovering people. It's all about, did you relapse, or are you going to relapse? It's not about what fuels that. So I like to think about, what are we missing during and after COVID? That we don't really have a place, an easy place or easy system of care that we can bring people in stable recovery from addiction and help them with those other life issues. So because I think we're kind of closing in on the time here, I would like you to think at this point, those are 3 examples, and we're gonna do 2. I'm gonna stop talking and let Abby talk in a minute. You ready, Abby? So I think what I'd really like you to do now that you've listened to all of our examples is really think about a place that you might start, whether it's the implementation of a clinical protocol that's driving you nuts and you know you should do it. Could you use the process improvement is great for structuring. How are you really going to do this? And then the other thing is to fix something that's like access, something that is driving you or the people you work with nuts. So Abby, Abby's going to talk to us about outpatient and engagement, and we're going to turn it over to you to give you a kind of different live example of what does this look like over a period of time. And I'm going to turn it over to Abby, and I'm going to mute myself now.
Thanks, Tommie. So I've designed a lot of different programs, and I don't have slides because when I watched the other ones of these, people were like the size of postage stamps, and I felt like it wasn't the way to go. But I started an organization. We used NIATx at the very beginning. And then at one point when CARF came to visit us, we had a 90% completion rate for 3 months and no staff turnover from the first time CARF came to visit to the second time. And what we had done is we had put in a lot of things into place. It was a lot of fun. I loved it. But there's a few things that we thought were really important. At the same time, I had 2 little kids and they were in a school. And the school's motto was be kind, work hard, and help others. And that is kind of the motto that I brought to the agency I was starting. And because for be kind, I would have staff do a welcome walkthrough, how to engage people early on. For working hard, the structure of the program, just maintaining a consistent structure and a safe structure, you can hang an awful lot of weight onto good programs. And we did outpatient and inpatient. And helping others. Staff wants to help others. That is why they are in the field. And how do you have a consistent staff, and how do you be consistent with staff? Johan Hari, who's a journalist who many of you have heard of, he wrote everything, he does a TED Talk about everything you know about addiction is wrong. His last sentence in that presentation is, the opposite of addiction is not sobriety, it's connection. And the idea of if you're nice to people, they stay in treatment, and if they stay in treatment, they tend to get better. So, so let's talk about a welcoming walkthrough. How do you do this? And I could do it, but I also, at the beginning, there were so few of us, but after a while I would have staff do it. One of the staff came in the front door. He said, oh my goodness, look at our brand is an arrow. People are going around the corner and looking for, so we had to be clear about that. But we thought about who we're working with. We're working with people who are feeling stigmatized, there's self-hatred, there's shame. If their family members are there, they are feeling the exact same thing. So the first thing we did was, what do you do in the first phone call? You don't collect information the first thing you do. The first thing you say is, that sounds really hard. And just getting people to do that, it made such a huge difference in the turnaround. We got a lot of feedback that this is the first time anybody's been nice to me. If you can't treat them, give them, for whatever reason, they live too far or what, give them a resource for them to find help. The front desk, we had God's gift to enabling codependent people. People came in and she was so kind to everybody. It wasn't like, sit there, wait. She would make sure there was chocolate for people who are in withdrawal. She would make sure there's water for people in withdrawal. And I think she alone kept, a big percentage of people coming back. We also, paperwork. I know you guys know all this, but we had a checklist for staff, checklist for clients, but we simplified it. I just recently went to the dentist. I had to fill out my name on every single page, even though it was online and you could easily populate it from one to the next. And so be kind to family members. one of the women I worked with said she had put her partner into treatment and paid for it. And she said, I always, when I was crying in with the clinician, I would have 1-ply tissues. And meanwhile, he's getting massages, doing yoga, meditating. She did not feel like it was fair. So we never had 1-ply tissues for our clients. Intake, look at the person. Tell them, I'm sorry I have to use the computer, or I'm sorry I have to use notes. I don't always take notes. I don't always do this. And we were very careful to make sure that the information we had to collect that first day could either be filled out by the client or was a very short amount of paperwork, enough to bill with, but not the full family history. And then we would talk to a peer ahead of time and say, you know, there's a young guy coming in today. Could you, like, when, you know, we release him into the group, could you make sure you kind of adopt him? And that worked really well. And we got people into the program as soon as possible because the program was the strength that we had to deal with. So how do you maintain the culture of welcoming and engagement in the structure? Everything you do can be, if you have a consistent program, if you have a consistent program, and this is stuff we did over time, it was not all at once, but sometimes we had very athletic people there and they would want to take, you know, do walks and all that stuff. And we had a lot of music and arts and things like that. So that clients had something else to bond over instead of just addiction. And that was really important. But when we first went to Blue Cross Blue Shield with our program, we have this program, we want you guys to, you know, help pay for it. They said, we're not going to pay for someone to sit around drumming all day. So, and when you add new staff, use their skills. So if you have a staff member who's a songwriter, that's great. If you have a staff member who's a cook, that's great. Use whatever you have. We reevaluated failures. There were plenty of those. We know what didn't work. People were feeling like the community meeting didn't work. So we tried like 4 different iterations of a welcoming community meeting so that it finally felt like it flowed better. And we had a specific structure. You'd have to hang things onto it. It might change what's exactly going on, but we always had, we would have a experiential group, educational group, and a process group every day so that people would do something together as a group. They would talk about their feelings and they would learn something. It may change what it is, but that structure was maintained, and you could, we also felt that one-stop shopping was the answer. That if people could also get their medications at the same place, they could get their mental health, they could get occasionally their health issues dealt with. And we integrated real evidence-based practices. We didn't just say evidence-based practices, we actually used them. And we would have people who stayed and stayed and stayed, and then we could graduate them to kind of our peer group. But we did have, for a good year or two, about an 85 to 90% retention rate for 3 months. And we had 4 rules, and and keep it simple, and they were all about safety, no threats, respect differences because everybody has them. Don't bring paraphernalia or get anybody else into drugs, and no isms. And the other part is work hard, be kind, help others. How do you get good staff when a lot of us don't have huge agencies? I mean, don't have huge staff. We can't pay staff what they deserve. We all know that. But so the first thing is how to get good staff and keep good staff. And why do people do this? It's because they want to help people. But for people who are managing programs, staff time is really precious. But it is the way to maintain the culture. So my rule was always hire half and half, as much as you could. Half people in recovery, half not, half foodies. It's very important if you can to hire funny people. I don't say that lightly, but a good laugh makes a huge difference. We hired a lot of part-timers. We hired a lot of older people coming back into the field after getting sober and having a career. So therefore hired a lot of ex-interns. To maintain the consistency you need to feed your staff emotionally and even actually, educationally, and help them foster a community amongst themselves. Share positive things. The other way people hated staff meetings. I'm sure that never happens with anybody here. We had all the administrative stuff sent out once a week in a note, and then staff meetings became places where people could do education. They could do, we could do projects together. They could work on NIATx together, things like that. And that was useful. But I think the most important thing is in agencies, it often gets lost, but supervision is the most important thing. People feel like it's expensive, but if you're going to retain people, you have to take care of them. You might not have to have the head clinician supervise everybody, but the head clinician might supervise the head of the house, the residents, and then the residents gets kind of the cultural view, and they supervise their staff. You might supervise the front desk person so that their culture gets spread. So because having a consistent, healthy clinical culture is what your goal is. So you want to engage people, you want to have consistency, and you want to have a good structure. So, and that, I mean, we actually had this amazing staff for a very long time. When CARF came the first time, and when CARF came the second time, and when CARF came the third time, most of our staff was still there. So I just want people to be kind, work hard, structure, and help others. Thanks a lot.
Apologies, Abby and Tommie, you're both unmuted. Oh, perfect. Okay, now I see that you've unmuted. Wonderful. Thank you so much, Abby.
Clever me. Okay, so we're going to pick up and finish this up and have a discussion, I hope. So Abby has mentioned things that were in it for the staff. Oh no, excuse me for a moment. We are not at the right place. There we go. So I want to just do a couple of little tiny things to wrap us up for today. And one is how and why you would change from fixing the things that are right in your face, whether they're from CARF or Joint Commission or complaints or whatever, or Atlas, to an infrastructure. And I think it's something, excuse me, worth thinking about. First of all, there is some evidence. There's a wonderful Harvard Business Review article about that people want to work for meaning. I believe people want to work for meaning, and it's also really nice when we can pay people. It's sort of common sense. When there was a time when Apple had its people sort of constrained by the product information leaking out, so they began to do more silos. And what happened was somebody noticed that a lot of the Apple employees were leaving and going to smaller organizations because they got to be involved with more, that it's interesting. So meaning, you know, if you have your small part and you don't have a conversation, meaning matters. We have some information that shows that, am I not muted or is somebody else not muted? I don't know. All right. So staff retention improves. We have some nice little data on that using improvement and involving them. It's a wonderful way to build new managers and see who your actual, your other layer of staff is. It's always nice when you can do things to make it easy for your staff to do the right thing. That's a goal, and for everybody else. There's a lot of draw in working for quality-oriented, mission-driven work. It's fun. It matters when you can try to help somebody and you don't have to spend all of your time thinking about the Xerox machine that's broken or that your phone system isn't working. And the other nice thing about doing change teams and change leaders and process improvement is you can put it in your company newsletter and give people some recognition. That's kind of hard to drive down within the organization. So for me, the issue is moving from the spirit of improvement to an infrastructure. And some of the reasons that I think it's important to consider this, even if you're just starting out and you're besieged by 1,000 different issues, is that what happens a lot is we layer innovation over our treatment as usual, that we don't have enough time to really fully finish the implementation. So with stigma and equity and co-occurring disorders, these are things that are often don't reach fully across our organizations, and they're harder to do. But so having attention to those kind of detail where you actually are working for transformation is worthwhile. It's much easier to implement new strategies, new concepts, and we're always going to have them, I hope, because we don't have a perfect fix yet for the problem of substance use disorder. We have more than we used to, but we aren't there. So it's easier if you have a system to do that and it becomes part of what you do. I'm going to jump ahead. My personal thing was, especially as I became chief clinical officer, I desperately didn't want to be in that position where the CARF person or the Joint Commission person came in and I had missed something. So being able to be predictably ahead, not just by quality assurance, but actually looking for the things that you can't see through these other mechanisms was certainly saved me lots of getting these white hairs. And finally, the thing we really want is to provide the best opportunity for a safe outcome for every patient every time. And when Victor Kaposha, who was in on the original NIATx stuff in 2003 and was actually responsible for pushing it to the Robert Wood Johnson Foundation, he talked about the importance of quality and safe outcomes, doing the right treatment, right patient, right time, going ahead and doing the ASAM, learning how to get the ASAM into your organization. These are all things that make it more likely that we will have safe and good outcomes, whether that outcome is the skipping stones and it takes quite a while, which happens frequently, or not. So I think of an infrastructure often is for me, can't be just the one person, the quality assurance person sitting in the office. It just won't work. It won't sustain. People will come and go. It has to be more widely distributed. And often you're ground down on the people who are just tearing their hair out because they know something is stupid and redundant and ridiculous and against everything they believe. They're the voices that you need to include in this process. So in conclusion, please take this to your work or wherever you work. Pick an aim that's critical to you. Pick any aim and something that matters to the people who are delivering you the service, because then you'll get buy-in and you'll have energy, and it's like dominoes aligning to get things done. And aim that will increase those goals, that we will give that compassionate care, that we will get the conversation on what the patient needs sooner than what the insurance company needs. No offense, but the burdens, there's the burden of illness, there's the burden of authorization, and the burden of public health mandates. Those things need to be sorted through in order to get us where we really want to be, which is that anytime somebody walks through the door, we want them to get what they need and reduce the suffering. So this is the end of my formal stuff. And if you want to call me or send me an email, I'd be glad to try to help you out. And you can write also to www.niatex.net. There's a lot of information about this way of doing business. So that's it. Are there questions?
Thank you so much, Tommie and Abby. That was absolutely wonderful. If anyone has any questions, you can go ahead and put it into the chat box, or I believe you can go ahead and unmute your line if you prefer to just speak it aloud.
And while you all are thinking of questions, I received an anonymous question via chat. So a reminder, if you want to submit your questions anonymously, you can just send it directly to me. I will not read your name out loud and won't convey your name to either Tommie or Abby. This person writes, I would be so interested in some kind of patient advisory board, but at an inpatient SUD level of care, it feels untenable. Abby and Tommie, do you have any advice there?
Sure we do. So you can have a patient advisory board based on trying to get somebody who's done well, who's maintaining some kind of reasonable life at the point. So we actually had lots of people are doing alumni groups that don't have to be fancy or provide lots of money. You can do this as a very small organization and invite people. You can do it informally, like an informal focus group, and ask selected people. Try to get a lot of diversity so that you'll hear things you don't want to hear, and invite them and make it a 6-month. Could you help us out for the next 6 months by giving us feedback, by being on our advisory board? Does that help out? Abby, do you have?
Well, I was thinking of, yeah, when we were having trouble getting people to come back to do kind of that, we actually had people who would come to it. There was this alumni group, and then we'd know they went to the alumni group, and come back and be official. We would ask them questions there, like what would have worked? What do you think? Kind of a less formal way of doing it. Ultimately, it became a patient advisory board, but it came and went as a success. But the other thing is suggestion boxes. When they were really well used, they were great. And we would leave them out even for the alumni groups.
Excellent. Okay. Somebody asked about that whole process of actually, doing all of the stuff that you have to do, the data you have to develop for admissions, treatment planning, without overwhelming the patient with suggestions. And Abby, did you find you had some strategies for separating out the pieces of the admission process. Of course, there are things that you have to do, the ASAM for your authorization, especially at the higher levels of care, that you just have to do. And it's not a great time to develop a treatment plan, but you have to at least have, the ARC in order to get your authorization. But did you have any ways that you thought were really good to help not overwhelm the patient with questions?
Well, we first of all, we'd apologize for overwhelming them. But the second thing we did was separate what they needed to have for insurance purposes. And that was the first part. And then that was done by an intake person or the clinician, whoever was doing the intake. And then the kind of the more detailed history, the family history, all that stuff that we needed clinically was done second. So you had enough information to bill for, and then we'd split it so that the stuff, like, we felt like it was, if you're an intake person, is you know, they're great, but if they're doing the information, you might not want to share the deep trauma with them or detailed family. So we really split the stuff that we felt the clinician needs to know within the first week, but not for the first day.
Okay. Can I add on to that if that's okay? I don't see anyone else chatting. Does anyone mind? That was my thing. So the example I'm thinking of is because we just had the Joint Commission here. So OASIS requires that we have our biopsychosocial assessment done within 24 hours at an inpatient level of care. And the first 24 hours at an inpatient level of care, just I think basically suck for everybody. That's my clinical terminology.
Perfect.
But then like you add another layer to that of the Joint Commission, and I just use a perfect example. They've been focusing a lot on trauma, which makes a lot of sense. And they say, you know, assess for trauma, neglect, abuse, exploitation. Like, and it's just one of those things where you're always sort of stuck between gathering all the information to make sure you have enough to like create good clinical care without you have to cast your informational net so wide to meet all of the standards. So it just feels like a difficult.
Yeah, we had to collect a lot of information on HIV and how people, or Hep C and how people got it. And we just created a checklist. And then for that, I mean, it's just, did you do this? Did you do this? Did you do this? Did you, you know, and instead of having to ask them all the questions. So, I mean, those kind of questions that we simplified, but yes, it's insane because everybody has different expectations. And a kid walking into treatment is not in any shape to be talking about trauma the first 5 minutes they're there, but we know that.
Right. So I think there's that, you know, those are the terribly difficult stuff that you're talking about where it just has to be pushed back upon, whether it's this person was so distraught and so ill with the withdrawal that in our first 24 hours, that would have been nice. Some of the things that people are doing are just absolutely not trauma responsive, throwing the aces at people who are undefended and have, as they say, not enough dopamine to get out of bed. This is just cruel. It's just not right. So I think you can say we have information from the family, or we're considering this diagnosis because of X, Y, and Z, because the person has a history of mental illness or hospitalizations for cutting or that kind of thing. So I think you just have to draw the compassionate line in the sand somewhere and do what you can the second day. It's really rough. It's not a reasonable thing to do with somebody who's in withdrawal, and maybe not the first time they meet you either, to get detail on things that there's no context. So it doesn't meet the standard of compassionate care or even sensible clinical care. It just doesn't. So I'm sorry that that's my opinion, and I'm sticking with it.
I also found that disclaimers with the clients make the big difference. Like, you know, if you don't feel comfortable answering this, or, yeah, I mean, it just, and build that right in.
Yeah.
I know. The answer is that there are too many people requiring too much paper before you can be kind to people.
Right.
But always look at them first and say, I'm really sorry about all this.
Yeah. Okay, we've got some other things in the chat.
So Helen says, I wonder what we could do in writing versus interview.
Yep. Yeah, I mean, I didn't think it was fair to ask all those questions about a lot of them. I would do it as a checklist. That's the distance helps.
So if you do an outpatient, maybe, you know, that this again is level of care and a level of acuity of presentation. It's a judgment call. And, you know, if you're sitting with, you're hearing the patient and you're hearing all those nonverbals, you have information that you can write as patient was extremely distressed during our conversation, hearing, crying, shutting down, flat affect, all of those kinds of things that would suggest a diagnosis. So you can record all of those kinds of things. The writing thing, so for people who are literate and are fairly stable, it's certainly a reasonable thing to do. I'm not sure exactly what the there may be some risks in asking questions, but it could be, you could do a simple kind of stability screener, some of the expert stuff where it's just really broad that would screen out for mood disorders or suicidality. And then if that person meets that criteria, then possibly open up for, would you be willing to tell us in writing some of the things that we would want to pay attention to together? So if you were establishing an outpatient relationship, I think that might be a way to do it.
I do think that engagement can really give you, I mean, just being with the client for a few minutes at the beginning can really make a huge difference in what goes on beyond that.
Right.
And the, talking, I'm really sorry about the computer, that kind of thing, but, it really helps. And having the other people they're interacting with be warm and fuzzy and welcoming is also really helpful.
Right. And then there's that, go ahead.
Sorry, Tommie, I wanted to probe just a little further on Helen's point about literacy. Mm-hmm. That's something that came up quite a bit when we were doing the patient experience survey. Patients who couldn't even go through the 10 questions on their own, and staff had to walk them through that. So do you have any advice or additional thoughts on how to approach this with that in mind?
That tell me question, can you tell me about this? The tell me. Would it be okay if I ask you a little bit about this and I write it down? It's just all transparency and it's a collaborative experience. Can we do this together? So you're really establishing an infrastructure of a relationship. At least that's what I've done. I double if there's there's sometimes my ability to understand someone who's not a native speaker is not as good, and I just am patient with me and ask for their patience to check out, have I heard what you say? Can I say it back? Those kinds of things. So it's an interactional, you're building an infrastructure of a relationship. Abby, do you have any better thing on that?
Well, I was also, be where the client is at, do as much as you can. And I don't know, we always had, we tried to surround ourselves with interns so that there were people around who could actually have the time, even if the clinicians couldn't. Mm-hmm. I mean, that's one of and then you have a ready-made group of people who can come be in your staff when you have openings too.
Right.
Mm-hmm. That's a great suggestion. I was just going to do a final call for questions. It looks like we have one that just came in. So if everyone could put questions in, we'll go ahead and address this one. We are getting to the end of time, so make sure you get your questions in. This one from Kevin. I appreciate the simple components that can be done that can lead to positive change, especially just remembering to be mindful, to be present with the patient, especially with the internal messages that may be sent to staff that are juggling multiple tasks at once, inclusion of collaborative documentation, and while maintaining your own self-care. Thank you.
Thank you.
Nice.
Yeah, very lovely. Yeah.
And from Joanna, sorry about the plug, but my company, Vista Research Group, provides online software that screens patients for depression, anxiety, trauma, suicidality, etc., and also collects a tremendous amount of information about what brought the patient to treatment in a 20-minute questionnaire, and that data is instantly available for the clinician. Thank you for sharing that, Joanna. From Helen, ideally, I think there are elements that can involve patient choice, such as many questions now or a few questions now, and then we can meet again later.
Absolutely.
Great,
yeah.
Helen. And that's all we have in the chat. We have a few minutes left if anyone wants to unmute and ask a question. Otherwise, I think we'll go ahead and start wrapping up.
Perfect. Well, thank you for the questions, everyone, and Tommie and Abby. Thank you for those presentations. Lots of good information there. Really appreciate it. Wanted to sort of just tie up the last few minutes here in terms of looking ahead for upcoming CQI opportunities as we look into 2021. We're currently looking at conducting webinars quarterly, and also introducing advanced level content that will really start to build on some of the key themes around quality improvement and technical assistance that we introduced and covered this year. So looking forward to bringing you more on that. Furthermore, we received feedback from attendees from our prior webinars, and we will look to sort of continue to build that into our future sessions as well. Some of those are listed here, as you can see. A few highlights were particularly helpful in terms of providing specific case study examples, and also exploring alternative payment models and how to work best with payers. So we'll look forward to seeing if we can add in some additional content on those items. Next slide. So in terms of resources available, we recently launched our CQI website, which is listed here at treatmentatlas.org/CQI. On the site, you'll find a lot of information on our previous webinars, recordings, supplemental resources, links to the provider clinical support system, and something that I'm excited about, and this will be coming soon, but case studies that will demonstrate how treatment facilities are using the Atlas data to drive quality improvement. But again, that'll be coming soon. Next slide, please. So in terms of feedback, here is some feedback that we received from our prior 3 webinars. Key takeaways here are that we're seeing increases in the number of survey respondents that found the webinars extremely helpful, and decreases in the responses of not so helpful or not helpful at all. So we look forward to continuing these trends in our subsequent webinars. Next slide. And so speaking of feedback, we would love your feedback based on the session today. After our webinar, you'll be receiving an email with a link to the feedback survey that you see here. In addition to the webinar today, we'd also appreciate your feedback on the Atlas professional portals. And the idea there is we want to continue to make the portals as useful as possible for our stakeholders as we look at sort of iterating the platform, again, to make sure it's intuitive and a good user experience. Next slide. So on behalf of the entire Shatterproof team here, my colleagues Carolyn Davidson and Leah Kaufman, I just want to quickly thank you all for taking the time to be with us here today. And I hope you all stay healthy and have a good holiday season. We'll leave the line open maybe for a minute or two in case there are any outstanding questions. But thank you so much. Appreciate everybody's help.